to commence this session, so feel free to take a seat. I'm Dr. Di Lawrence. I'm the Executive Director of Medical Services here at Salen, also a paediatrician, and really delighted to be chairing the session this afternoon. So before we start, just want to do the acknowledgement of country. So we acknowledge that the Kaurna people are the traditional custodians of the Adelaide Plains and the lands that we meet on, and pay respects to their elders past, present and emerging. We recognise and respect their cultural heritage, beliefs and relationship with the land, and acknowledge that they are of continuing importance to the Kaurna people living today. So thank you. I'm delighted we've got some different speakers this afternoon. So we're going to start off, really delighted to introduce Dr. Bernadette Alaprandi Costa, who's actually visiting us from interstate, from the Australian Commission of Quality and Safety in Healthcare. Many of you would know the Commission. I know it inside out, given I'm the Clinical Governance Lead for Salen for National Standards. But Bernadette is the Manager of the Safety and Quality Improvement Systems and Intergovernmental Relations team at the Commission. It's a key agency, government agency that leads and coordinates national improvements in safety and quality in healthcare, and working in very close partnership with the Australian Government and all the state and territory governments, private sector, consumers, patients, importantly, clinicians, managers and healthcare organisations. Bernadette has a PhD in health outcomes research from the University of Sydney and has led programs of work for the development of clinical trial services, clinical quality registries, quality improvement, health service performance reporting and health service funding models. She's delivered several initiatives on behalf of the Commonwealth, states and territories, including the National Clinical Trials Governance Framework, national consultations on the One-Stop Shop and National Clinical Trials Front Door, and currently a National Quality Standard and Accreditation Scheme for Human Research Ethics Committees under the National Mutual Acceptance Scheme. Bernadette is also leading the revision of the framework for the Australian Clinical Quality Registries to ensure that the framework provides a quality standard and national arrangement by which all of us clinicians, health service organisations and jurisdictions working in partnership can authorise and secure health record level data to measure and report on the appropriateness and effectiveness of healthcare. A really, really important role, and the clinical trials framework is really important, exciting work. So thank you very much, and we're delighted to have you come and be with us today, and thank you for travelling. Welcome, Bernadette.
Can you hear me if I speak, or do I need to use this? I should use that. Okay. Thank you so much for the invitation to speak with you today. It really is a privilege to be able to attend these meetings in person and to meet with you, because the Commission can take so much from the initiatives that you've been implementing here at Salen. So I always begin with this slide, and this is so that you understand the Commission's role. We were enshrined in legislation in 2011 under the National Health Reform Act. So that means all our functions are provided in that Act. We operate as part of the Commonwealth portfolio, health portfolio. Our chair of our board is appointed by the Minister for Health, now the Honourable Mark Butler. And we operate via agreement and funding, co-funded by the Commonwealth and the states and territories. And we have a work plan that they set out for us that also aligns with our functions. So under the Act, we have functions that include to lead and coordinate improvements in safety and quality in healthcare by identifying issues, policy directions and recommending priorities for actions. We formulate standards, monitor the implementation and impact of those standards. We formulate national accreditation schemes and use data to report back to the Health Minister on matters relating to safety and quality in healthcare. So what does that mean? Well, the Australian Health Service Safety and Quality Accreditation Scheme is one such national scheme, and it's underpinned by 5 relationships. So the Commission establishes the scheme and coordinates the scheme. We develop the National Safety and Quality Health Service Standards. We also report to health ministers on matters relating to safety and quality. And we also have a liaison role with the state and territory and Commonwealth governments. So on issues of concern for them that we're able to address to minimise the duplication that might otherwise occur if other agencies undertook that role. We also run an education program for accrediting agencies, and then we approve those agencies to undertake the assessments of health service organisations to the national standards. So health ministers, they endorse the standards and they also receive a report on the outcomes of accreditation. State and territory health departments nominate the health services that we are to assess and accredit, and they also receive information on the outcomes of the assessment, and then they're able to address issues as they arise. The accrediting agencies are then contracted by health service organisations whose role it is to implement the standards, and they undertake that assessment with agreement that the outcomes of the assessment will be shared with those health government departments. The Commission also provides support to health service organisations, so we do that with guidance documents and also by running workshops and by engaging with health service organisations. We are not arm's length from you as you move forward with implementing the National Clinical Trials Governance Framework. It is an important role for us to make sure that we support you as you move through this process. So just to recap again on the work that we're doing and how that aligns with our functions. So the National Safety and Quality Health Service Standards comprise the National Clinical Trials Governance Framework. So there are 27 actions in Standards 1 and 2 that will be implemented nationally from January of next year. And so that aligns with our role to develop national standards and national accreditation schemes. Ultimately, we are aiming to embed research into health service provision. And that's because under the National Health Reform Agreement that the Commonwealth has with all the state and territory health departments, hospitals have three functions. They deliver clinical services, they conduct research, and they deliver education and training. Another project that we've undertaken recently, the ultimate aim is to harmonise systems and processes nationally, and national consultations on the National One-Stop Shop and the National Clinical Trials Front Door. So that is a single national human research approvals platform that would also facilitate the functions of the Therapeutic Goods Administration, their CTA and CTN processes. It would also support and underpin the registration processes with the Office of the Gene Technology Regulator, and it would also enable health services to report against their research operations as required in the National Clinical Trials Governance Framework. So currently the research systems that are in place, while you can put through an ethics application, you can't actually use those systems to monitor your operational performance at the level where the activity is occurring, and that's in a clinical trial site. As part of those consultations, we were also asked by the states and territories in the Commonwealth to finalise those minimum core requirements that would comprise the national SSA. So what does a health service organisation need to consider when they're undertaking a risk assessment to do research on their premises? It has always been there. Since research has been conducted, the health service organisation has always signed a contract to say that they're able to carry out the research. In 2009, that process changed to the SSA process. The policies that underpin that process were different in each jurisdiction, and how they were interpreted at an individual health service level also differed. And so that has been identified by the states and territories as really one of the single thorniest issues addressing timely research startup in this country. So we've completed that round of consultations as well, and now we've reported back to the Commonwealth and to the jurisdictions via the Clinical Trials Project Reference Group. So those final core elements are now sitting with them, as well as the final consultation report. Another piece of work that we're undertaking again to harmonise systems and processes, again aligned with our function to develop national schemes, is that quality framework for ethics committees and an accreditation scheme. So we've just commenced that work with a literature review and an expert advisory group, and we're hoping to have that first draft ready by the end of the year for consultation in the first quarter of next year. Another piece of work that aligns with our functions is to improve access to health information by health service organisations so that they're able to meet the National Safety and Quality Health Service standards to monitor variation in practice and outcomes. And that's through the revision of the clinical quality registries. So why did the states and territories ask us to develop a national clinical trials governance framework? It was to strengthen governance arrangements for health service organisations that deliver clinical trial services so that we can achieve those benefits for consumers, patients, sponsors, and trial investigators and governments. So a single national approach to be implemented in a unified way across all health service organisations nationally. The goals are to integrate clinical trials, as we know, into existing clinical and corporate governance systems. We didn't set out to achieve another separate siloed system that health services would be asked to implement, but to use those systems and services currently in place, but to now bring research under the purview of the governing body. The governance framework was endorsed by all jurisdictions at the beginning of this year, and we are moving forward with implementation from January of next year via a maturity scale. So each hospital has 3 years to achieve the actions within the governance framework. So they'll be assessed against the maturity scale. So when health services come up for accreditation, they will also be assessed for clinical trial service provision against that maturity scale, which I'll go into in a moment. The last time I was in Adelaide, it was really to socialise the idea of those actions in the National Safety and Quality Health Service Standards, and that was in early 2019. And we came to Adelaide and we met probably with some of you. And from that, from that engagement, we actually took away suggested strategies that we've now implemented into the governance framework, as well as examples of evidence that you might provide to an accreditation assessor. So just to cover off on how it was developed, we undertook a very detailed literature review. We mapped all jurisdictional legislation, regulation, policies and processes across the country. Those documents are publicly available on the Commission's website. We then undertook the national consultation process in person by visiting each jurisdiction. We then refined it and we tested it through a national pilot of 33 health service organisations. So those health services, we had them located in each jurisdiction. They also represented metropolitan and regional centres. And so we had a good breadth of exposure to health service organisations and their levels of maturity in their ability to implement the National Safety and Quality Health Service Standards 1 and 2. And now we're moving towards that embedded approach. So the definition of governance as it applies to the national standards and the National Clinical Trials Governance Framework is a whole of organisation approach. It isn't a definition or a role and function that is siloed in the research office. Every trial coordinator, trial investigator, health manager, clinical and non-clinical manager, finance, HR, and the governing body have a role in implementing the governance framework. And part of the pilot, we began with sessions whereby we introduced the clinical trial services to the governing body, and we tried to build that relationship so that one had visibility of the other. Even though services are delivered in health service organisations, we know that they were often separate and siloed, and there were various reasons for that. So building those relationships across the organisation is a first step in implementing the governance framework. And I have to say, it's been so inspiring to see the work that Salin has done under the team and under the guidance of Professor Burston, Simon Winster and I, to really bring the whole workforce into implementing the governance framework. So the maturity scale we tested and validated through the pilot. So we designed a system that was based on having initial systems in place, so those health service organisations that were just really coming to grips with what the standards meant for them. Those that had growing systems in place, so they had somewhat implemented the actions within the standards, and those that had established systems, so they met all 27 actions in the standards. We then developed an assessment scale, so 1 to 1.99 was initial, 2 to 2.99 was growing, and 3 was established, so that we were able to create an average at the level of the clinical trial unit, and then also an average at the level of the health service organisation, so that they could get an overall rating, but they could also get feedback on how they tracked against each action. So it gave them an opportunity to see where they would need to improve. So how does this align with the national standards? So the importance of working through the standards is, as I said earlier, it wasn't to design yet another accreditation scheme or another hoop that hospitals would have to jump through. It was to work through existing mechanisms. So the National Safety and Quality Health Service standards already provide a robust governance framework. They've been designed with a safety and quality focus and, importantly, a consumer focus. And hospitals have already invested in them, so it was important to us that we use that existing mechanism. They're also in place a nationally consistent approach to assessment, so we also sought to work through that process, but we also found that it wasn't fit for purpose as we moved through implementing something new, and that is why we implemented the maturity scale. We know that something that's implemented slowly, that brings people along with us, means that it's likely to stick. So these are the 5 components of the National Clinical Trials Governance Framework. It is underpinned by 7 core principles. It is patient safety. The framework is based on patient-centred approaches, safe environment, quality, risk and proportionality, equity, accountability and transparency, and organisational culture. And these specifically relate to the way clinical trial services are delivered. How they relate to the first 2 standards of the National Safety and Quality Health Service standards are these. So the first 4 standards are under the clinical governance standards: governance, leadership and culture, patient safety and quality improvement systems, clinical performance and effectiveness, safe environment for the delivery of care, and the partnering with consumers standard. So how do you prepare for assessment? In order for us to move now forward into the implementation phase, the Commission has finalised the governance framework. It is available on the Commission's website. We've also developed case studies that, so these were insights that we gained from the pilot. And as we move through implementation, where we see exemplar practice or examples of innovation, the Commission will also publish those on our website. Accrediting agencies are required to feed back to the Commission on exemplar practice, and then we work with those health service organisations to gain their permission to publish on our website, and that gives other health service organisations the opportunity to learn from good practice. So I will be asking Simon and Professor Burston and others if we can also provide a link to the work that you're doing here at Salen, even on the communication with your workforce, because I think that would be really interesting for other health services to learn from. In terms of our internal processes, it is quite a process to get a scheme up and running in a different clinical area. So we are currently creating the training for accreditation assessors. They will all have to pass our clinical trials education program in order to be approved to assess health service organisations for clinical trial service provision. There is some transition planning that we need to do with health service organisations. So we know those health services coming forward in the next 6 and 12 months, and we're working with them one-on-one as they begin to prepare. Now, obviously, those sites will be in the early stages, more than likely, of implementing the actions within the framework. So we'll work with them as they move through that process, and then they will have the remainder of the first 3 years to really make sure that they're able to meet all the actions. We're also updating our internal data collection portals. So this is where the assessors report back to us on the outcomes of the assessment. So there's some coding and things that we need to do internally. We're also updating our fact sheets for clinical trial services, and we're also updating the public portal that the Commission developed to help you undertake a self-assessment against the standards, as well as to use the portal for your reporting on trial operations. We know that that capability isn't available in many health service organisations. We heard that through the first phase of consultations back in 2019. How can we possibly measure our operations when we don't have a mechanism to do so? So we built a portal for that purpose, and we know that that's yet another separate siloed system, but under the one-stop shop, hopefully that issue will be addressed. That portal will remain in place until there is another permanent solution. We are also putting in place our oversight committee arrangements. So on that previous slide I showed you, the Commission reports back to state and territory governments, and we refer to that, part of that relationship as a regulatory committee, because jurisdictional health departments fund health service organisations. So we will be seeking to have representation from the Clinical Trials Project Reference Group on that regulatory oversight committee. So the first questions that you should ask as you begin to prepare for implementing the framework: are you familiar with the framework? Have you read it? As we moved through the pilot, it was really clear that people would just jump to the actions or the strategies without fully reading the governance framework and understanding the core principles and the concept. So it's really important to read the governance framework and understand what you need to do to implement within your health service organisation. Understand who is your accrediting agency and when is your next assessment due, and who is the person or the team that coordinates the assessment process in your organisation. You need to understand where activity is occurring. We know that clinical trials are conducted across multiple clinical departments. They're not necessarily in one area. They're often not even known to the heads of departments or to the executive of an organisation. It could be a single investigator doing projects in a fairly siloed way. So do that environmental scan, understand the breadth of activity occurring across your organisation, allocate resources to that working group or to the Safety and Risk Quality Office, whoever it is that coordinates the effort in your organisation, and undertake a self-assessment. And you can use the Commission online tool. There is a spreadsheet that safety and quality officers have been working with for many years against the standards, but there's also an online tool, and you can share that tool and allocate activities to different individuals and ask them to undertake tasks, and then they can upload examples of evidence into the tool. You can collate all your evidence, and you can do a self-assessment that says I'm 40% met, 60% met, or 80% met, or 100% met of any of the actions. So you can track your progress in that way. One of the difficulties that health services had, and I would say every single health service in the pilot, were unable to demonstrate that they could report against all 8 KPIs that hospitals are now required to report against for their clinical trial service provision. Some could report on a subset of these KPIs from the level of the research office. Nobody could demonstrate that they had capacity to do this from the level of the research unit. We had a lot of conversations with different jurisdictions during the pilot saying that they could do it, and the Commission's view is you do not have to use our resource. You can use whatever resource you have. We're not asking you to duplicate it. If you do have capacity or you have created a tool, use that tool. But if you don't have anything in place, you are very welcome to use the Commission's tool, and we will be maintaining it for that purpose so that there's equity across all health service organisations in their ability to report. The reports that the tool generates can be automated, or you can download all the data that you put into it. There are essentially 5 denominators and 10 numerators that you can enter in, usually dates. So it's usually calculating a range between 2 dates in terms of timeliness of review. You go in and you enter a recruitment activity as it occurs. So it is, from that perspective, that would be a manual update to the system. But you can download all the information into Excel spreadsheet, do your own analysis, or just generate those reports and share them with your governing body at least quarterly. That's required in the governance framework. Now, clearly, as we begin this process of implementation, you may not have a lot of data in there. We're saying begin with your recruiting trials first. We're not suggesting that you would go back and retrospectively enter all the data of clinical trials that are now closed. So a pragmatic approach in the first instance, but certainly you will not be able to report on just a subset of your activity, so that will be assessed. We did see a little bit of that in the pilot, and that opportunity to game is not ever going to deliver the outcomes that we're seeking to achieve. These KPIs, by the way, were developed in consultation with the sector and in those jurisdictions that already had reporting processes in place. So we know that these are capable to capture, they're not onerous, and it's aligned with the national aggregate statistics. So I know Simon is going to speak to this in a moment, but a good place to start is with your organisational chart. Is your service reflected in the organisational chart, and is it reflected in your organisational operations? Capture all the details of the activity where it's occurring across your organisation, including the contact details of investigators and trial units. All of this information will be required to be provided by the accreditation assessors. Now, the executive are very familiar with this process. They already provide this information for clinical service provision and corporate service provision. It's just now required also for clinical trial services. So they need the list of trials by trial phase and name, the sponsor type, because there is a principle in the governance framework around equity. So we're not just looking at commercially sponsored trials. There is also, health services are also required to support investigator-initiated trials. And we know that the support for those trials is different to the support that they may provide to commercially sponsored trials. The name and position of the clinical trial investigators, study coordinators and other individuals, the number of staff allocated to the trial and the number of participants recruited. And that enables the accreditation assessors to undertake a sampling. So they will sample across the organisation just as they sample clinical services, and they interview all of the participants in service delivery as well as patients. They'll sample across all of the clinical trial services so that they can meet with members of each of these groups, as well as trial participants and trial sponsors. There is a video on the Commission's website which I won't play. It's a very simple video, a very simple introductory video if you did want to have a look at that. But I'll move through now into what the assessors will do as they begin to plan with you their assessment. They will ask for all of this information. When they asked for that as part of the pilot, that was quite a shock to clinical trial services. They've never had that visibility in their organisation previously, but all of this information will be required. They will then determine the scope of the assessment. They will undertake the site sampling. They will look at the volume of trials, the department and specialisation, and they will begin to make that plan. So ultimately, if you're a large metropolitan service and you've got a large number of trials, they'll look at a proportion of all your trials across all phases of trials and all investigator type. They will review all the information that you provide. So you will upload all your examples of evidence to them prior to the assessment. They review all of that documentation prior to the assessment, and when they come on site, 60% of the time is allocated to reviewing the trial service operations, including interviews with all the key stakeholders. And then they will, what they're seeking to do through that process is actually seeing if the people they interview can articulate the examples of evidence that they've received. So can they articulate the policies and processes in place? Can they articulate the reporting requirements and those arrangements with their governing officers? So this is a very high-level summary from the pilot of the groups that the accreditation assessors met with: representatives of the board, the Health Service Organisation Executive, the commercial sponsors. So this was quite new. Commercial sponsors and any trial sponsor really have only ever had a relationship with the trial investigator. As part of the governance framework, they need to be communicating more transparently with the Health Service Organisation on issues as they arise. It's not to be siloed at the level of the trial investigators, so that the safety and the quality and the conduct of the service is really known to the organisation. They will speak to finance managers, human resource managers. They will be seeking to understand how a health service organisation retains a skilled and reliable clinical trial workforce. That is one of the actions in the governance framework, and we know that that's a real issue for health service organisations. Currently, in many health services, trial coordinators are employed on contracts. The Commission does not dictate how a health service organisation employs and engages its staff. But we've got good examples now on our website of where jurisdictions have moved towards having pools of trial coordinators, so permanent employees on staff that they can rotate across their organisation and backfill trial units when they need to be. So these are some of the challenges that the governance framework seeks to assess. And so all participants will be invited to participate in the interviews. A schedule looks something like this. This is very much an abbreviated schedule. It was the schedule that we undertook as part of the pilot. But essentially there's an opening meeting with the organisation which everybody is invited to. And then there are separate meetings with different individuals and groups across the organisation. They undertake their reviews, their walkarounds, and then they come back and speak to the primary point of contact in the organisation before having a close-out meeting. Now, this can be over several days, over 5 days, but it's a schedule that comes through and is planned with the organisation well ahead of the assessment. The methodology that assessors use is called PICMORS. So how do they assess that a health service organisation has met the actions in the framework when health services are so different? They're located in metropolitan and regional and remote locations. We're not suggesting that all the roles and responsibilities of individuals as provided in the governance framework all exist in any one health service organisation. We know that some health service organisations have a single individual undertaking multiple roles. We provide the guidance, but health service organisations implement the governance framework as best meets their needs. So this is the methodology that the accreditation assessors follow to help them undertake an evaluation that minimises bias. So they look at process, examples of improvement, levels of consumer participation, how those processes are monitored, reported and shared across the organisation, and what systems do they have in place. So once again, going back to the assessment process, there is the preparation for the assessment, which you will be doing well ahead of your assessment date, and then there will also be the preparation that you will do in partnership with your accrediting agency. They will then prepare the assessment by reviewing the documentation that you provide and reviewing all the systems that you have in place, and then they'll set up the interviews. They then undertake the assessment and determine the degree of maturity of the organisation against each action, and then they will prepare a summary report which they will provide to the organisation, and then the organisation has a set time frame in which to read the report, provide feedback to the accrediting agency before the outcome is finalised and the report is prepared for the Commission. So a little bit more on the maturity scale. Initial systems, growing systems and established systems. I would just encourage every health service organisation to make use of this opportunity. I don't think you need to race ahead and, try to have everything established when clearly your workforce is perhaps not engaged in the process, but to start at the ground level, to start with your clinical trial unit staff, investigators, trial coordinators, supporting departments, pharmacy, pathology, and make sure that they're on board and they're aware of the actions. So established systems are those health service organisations that are quite mature. They're already meeting the actions within the standards for clinical trial service provision. We saw 3 health service organisations through our pilot that met the actions within the standards, reporting against the 8 KPIs being the exception. And I'll give you an example of one health service organisation shortly, but we do have some good examples in case studies up on our website currently. So growing systems, as I said earlier, they are making some way in embedding the actions within their governance systems. They are particularly challenged by areas around risk and incident management. Some of the feedback on what we saw through the pilot was clinical trials are very familiar with reporting adverse events to the ethics committee and the sponsor, but they have no awareness of incident and risk management systems that currently exist in hospitals. So a death of a trial patient will be reported to the ethics committee and to the trial sponsor, but the health service organisation may not know about it. So building those relationships across the organisation and in particular with the risk, safety and quality team is key for this group. And those health service organisations that have initial systems, they're committed to implementing. There was a lot of positive engagement in implementing the framework through the pilot, and where we did see these health services at this level was really in regional sites, and we know that there is more work to do there, and the Commission is very committed to supporting those health service organisations, and the barriers that they experience were also what was observed by the accreditation assessors when they entered those organisations. So key learnings, key challenges from the pilot: evidence of workforce engagement, evidence of sponsor engagement, ways to communicate trial operations across the organisation, and evidence that the workforce understood their role in implementing the governance framework. Another area that presented a particular challenge was that feedback to carers and trial participants, so the consumer engagement. So often there was insufficient evidence. They could sometimes describe what they do, but there was no evidence to demonstrate that they were actually doing that. Actions that were most frequently met through the pilot included health service organisations could demonstrate that they had an open disclosure program in place, or that they were able to, the patients had capacity to make decisions about their own care. So those actions, some of those actions that aligned with the clinical governance standards were those that were most frequently met. Consent for clinical care was most frequently met, and that they had a clinical governance framework in place. There are a plethora of resources to support health services as they move through preparing to implement the governance framework. So there's the National Model Governance Framework, there's the National Standards User Guide, there's the Australian Open Disclosure Framework. The Commission has a number of resources to assist health services in their partnering with consumers. And there are other resources as well that have been developed by other organisations such as the NHMRC. All of these resources are listed on the Commission's website. There are also resources to assist health services implement the actions for Aboriginal and Torres Strait Islander people. I know I only have a couple of minutes to go, but I do want to touch on this because I think it's important. We are often asked about the costs for implementation, and we did seek to calculate those costs as part of the pilot, even though the regulatory impact statement, so anytime something new is introduced into a hospital, it has to be evaluated. The cost of that has to be evaluated. It's called the RIS. The National Safety and Quality Health Service standards were assessed in 2016, and because the actions, it's only a subset, only 27 actions in standards 1 and 2 comprise the National Clinical Trials Governance Framework, we did want to make sure that we understood the level of resource allocation that health services would need to invest. So as part of the pilot, and it is publicly available on our website, we looked at the location of the health service, the type of health service organisation, the number of trial units within the health service organisation, whether the health service organisation was assessed to the first iteration of the standards or version 2, which were released in 2018. And we also then looked at the costs. They were self-estimated costs. The Commission didn't go back and undertake a formal verification of the costs that were estimated, but we did ask the CEOs of those pilot organisations to sign off on them. So we created costs against 18 cost groupings. They were then costed into 9 reporting groups: policies and procedures, record keeping, training, IT infrastructure, physical resources, education resources, consumer engagement, so effort required to engage with consumers, and other types of effort that may be required. And then we group them into 3 groups: implementation costs, compliant costs, and additional costs. So we did have pilot sites who didn't achieve an established rating that said that there were no costs associated with implementing the framework because they had already implemented policies and processes to meet the actions, so they reported as 0 costs. There were no missing values in our cost estimate calculations, but there was a huge spread around the mean cost for implementing the governance framework. If you were a large metropolitan hospital, the costs were much less. They estimated establishment costs to be around $200,000, with a maintenance cost of about $100,000 per year. And if you were a regional site, those costs could be 3 times the average. So we know that there is effort across a health service organisation to implement the framework, but we know we are also working towards implementing the framework into existing systems and processes that are in place. I don't know if I have time for a brief case study. I was actually going to show you Darwin Hospital, but I'll begin with the Alfred. This was a hospital that did demonstrate, as did Darwin, established systems in place. And while not everybody is a very large metropolitan hospital, it's good to see what they do and just to take examples that might be applicable to you. So it is a very large hospital. It does have a large number of clinical trials opened, and they could clearly demonstrate that they met the actions in the governance framework. And Nicole Rasmussen, who was the clinical safety and quality officer there, also provided some feedback on the launch of the governance framework, so that interview is also available on our website. So just speaking on that, it's really important to hear the views of the various participants. In the launch video, we did try to have representatives of people from our advisory group that represented hospital administrators, trial investigators, the Commonwealth, trial sponsors, trial participants, trial coordinators, because their views matter. They contributed to the development of the governance framework. They have a role in implementing the governance framework in their health service organisations. So hearing their views is really important, and so that's why we find the work you're doing here so inspiring. So their overall approach, they had really good engagement with their executive. They could demonstrate that for a long period of time they'd had regular meetings. They had a research governance framework guideline already established and in place. They did have a research leadership and governance committee. They had a project officer that coordinated all the effort. Now, we know that's not possible in every health service organisation, but on a much smaller level, there could be something, a working group that you could implement in your organisation. There was broad engagement across the organisation and a clear understanding of the governance structure, the roles and responsibilities of individuals. So they could demonstrate that they'd incorporated research into their strategic plan and their organisational structure. They had delegated roles and responsibilities that they could not only demonstrate in the evidence that they put forward to accreditation assessors, but this was also captured in the interviews that the assessors did through the assessment process. They had risk management policies and frameworks and guidelines in place. All stakeholders provided information about safety and quality performance at some level within the organisation, and they could demonstrate that they had a patient feedback guideline and nice processes for collecting and reporting on patient stories. In terms of their partnering with consumers, they had a consumer registry of over 100 consumers. Once again, that may not be possible in all health service organisations, but adapting these approaches to your own would be useful. They had KPIs as well for partnering with consumers and guidelines in place. They had a patient information working group that they established to improve and assess how they communicated with patients, and they also had a number of patient stories which they could share. In terms of their meeting the actions for Aboriginal and Torres Strait Islander people, they had policies and processes and guidelines in place. They had a reconciliation action plan in place, and they had an advisory group to support the planning of initiatives to deliver safe and culturally appropriate care for all Aboriginal and Torres Strait Islander people, and they also had specific KPIs for that. And they also had a working group to establish discussions with communities that they were providing care for. So I might pause there, and I was just going to move through another case study, but I think I'd like to go and seek any questions. Pat? Oh, all right. So the Royal Darwin was also a hospital that demonstrated that they had established systems in place. And I just want to preface this was a pilot. So this was the first time that accreditation assessors had ever stepped in to assess a clinical trial service. And the Royal Darwin was only the second health service that they assessed. We were very careful through the pilot to engage one commission registered agency. We trained all 4 assessors on the national statement and policies and processes with which clinical trials must comply. This is a new area for them. And so the Royal Darwin was only the second hospital that they assessed, so it was quite a new experience for both. So this is a regional public hospital. It serves over 200,000 people. It has less than 100 clinical trials opened, but it could demonstrate that it did meet the actions within the governance framework. So they established a small internal working group to oversee the implementation of the governance framework. It focused on engaging all members of the workforce in that working group. It had really strong and effective support from its executive. They engaged early with their safety and risk quality officer. So that's the first time that they had needed to engage with this person, and often we saw this repeatedly throughout the pilot. It was the first time that the risk and safety quality officer had any awareness of clinical trial service provision. They embarked upon some educational opportunities to increase the awareness of the governance framework across the organisation, and they began a process of broad engagement to bring everybody on board as they moved towards the pilot. So there was a lot of effort in participating in the pilot. So you can see how these cost estimates were reflective of the effort that they were putting into genuinely implementing the governance framework. So they could demonstrate when the assessors came through that they had incorporated research into their strategic plan and into their organisational structure, that they could identify the roles and responsibilities for safety and quality in clinical trials were included in position descriptions for trial coordinators and also for trial investigators. They had a clinical innovation and research committee which was chaired by an executive member of the leadership team. They sought to use their operational data and trial findings to discuss at their clinical trial unit quarterly meetings. So this is the first step to fulfilling that process of a clinical trial and feeding back the outcomes of trial results into your care that you're delivering. So as part of the governance framework, you need to demonstrate not only that you're communicating on your operations, but how the outcomes of the research that you're doing being fed back into improved care. They could demonstrate that they were using the incident and risk management systems and that they could collect patient experience through a series of surveys and online forms and feedback cards. In terms of partnering with consumers, they established a health advisory committee and a consumer advisory committee to promote and facilitate community consultation in the delivery, how the design of the clinical trial service and how consumers could participate. They ran some participant satisfaction surveys that were appropriate in different languages for Aboriginal and Torres Strait Islander people. They also had a participant experience and consumer engagement and stakeholder group. And they developed a number of resources and contact details for the different services. So specific to the Royal Darwin, they adapted their materials in a way that it could suit their level of service provision. They were really strong in their ability to demonstrate a collaborative partnership with Aboriginal community-controlled health services and the primary health network in the Northern Territory. They had already in place Aboriginal key performance indicators. They had a reconciliation action plan in place, and all their staff already underwent cultural awareness training, and they had a number of senior executive staff who identified it as Aboriginal and Torres Strait Islander, so they were very strong in this regard. So that's just another example of how the governance framework will be implemented based on the health service organisation and its location, and based on the community and the needs of that community that they're serving. I might pause there. Thank you.
Thank you, Bernadette. Don't run away. We may have some questions for you, if that's all right. We've got 3 more speakers, but before we go to that, I've actually got a question, if that's all right. Thank you for explaining that with such clarity. It's one thing to read a framework, it's another thing to hear about it. We're going through a planned assessment accreditation in June of next year, and you explained really well the approach to a planned assessment. My question relates to following July 23, when hospitals go to short notice assessments, and what that would look like in relation to this framework.
So there will be short notice assessments will include clinical trial services. So while you won't have a date for the assessment, you know whenabouts it will occur. And so that's the message is begin to plan. In July of next year, if you don't achieve all the actions in the framework, that's okay. You've got time to plan, and I would use these first 3 years to plan in a genuine way to embed the actions of the governance framework, and not to panic about the short notice assessments, but to participate and to use this as an opportunity to build and plan. But they will be assessed as part of those short notice assessments.
Thank you. Any questions from people in the room? And I can't see any questions on the app just yet. No? Thank you. Thank you, Bernadette. So we'll move on to our next speakers. We've got 3 more speakers. The next 2 are from our own Sarlan Office of Research. So we've got Simon Windsor. Many of you know Simon. He's the manager of our Sarlan Office for Research and Ethics, and he's worked with us for 5 years. He is a Flinders Uni alumni as well. During his 17-year career, he started in SA Pathology and CSIRO, and he's worked in the UK, Singapore, New Zealand, and throughout Australia. Has a keen focus on innovative problem solving, optimising research management, and forming effective relationships. So reach out if you would like to. So it's great to have Simon here. We've also got Karen Saxty, who also works in our research office, and she is a research governance officer for Sarlan and has an extensive background in bowel cancer prevention and surveillance, and she's been with us for 22 years, so which is amazing. So welcome, Simon and Karen. Thank you.
Thank you so much, Di, and it's really great that you're able to chair the session today. It's a real privilege to have the Executive Director of Medical Services being able to support this initiative, and we're really grateful that Bernadette has joined us from Sydney today. So yeah, we're very, very grateful for that. So what we're looking at today, discussing the Southern Adelaide Local Health Network Clinical Trial Framework. So yes, Simon Windsor, Manager of Research, Governance and Ethics.
And Karen Saxty, I'm the Research Governance Officer.
So we've got a post-pilot case study here. So you had case studies in the pilot, and this is a post-pilot case study based on some of the resources that the Commission has developed. And so we can have a look at the what Sarlan is. So metropolitan, multi-site, local health network. We've got 20 sites. The South Australian Southern Metropolitan region that we provide services to has 350,000 people in it. We've got 8,500 staff, real mix of disciplines, over 300 trials that are open at the moment, and we have accreditation in June, early June 2023. So that's why it's really great to be able to discuss it today and just see all of that detail that you've given us.
So our overall approach to addressing the accreditation process is that our oversight would remain with the Clinical Council, but we would report to the Clinical Council annually on our progress. We have undertaken an initial gap analysis to identify any action items in relation to Standards 1 and 2, and we consulted widely with our community of practice. And based on the above, we organised a planning group, and we had representation from our Partnering with Consumers group, our clinical governance team in terms of safety and quality, our finance team, our clinical trial coordinators, and we also consulted with our electronic medical records team so that we can document the patient journey accurately via Sarlan records, and we also consulted with our consumer advisory service and risk team. In terms of providing education to our workforce, we embedded a clinical trial module into our corporate induction, and this involved information and education in relation to clinical trials, research methodology, ethics and governance processes, as well as safety and quality standards. In terms of communication tools, we have developed a number of communication tools in terms of the accreditation process, and we've used a number of platforms for these, and they're distributed across Sarlan.
So just to firstly look at leadership structure that we have here in Southern Adelaide. Professor Andrew Burston, he's the Executive Director of Medicine, Cardiac and Critical Care, Ambulatory Care, as well as the Executive Director of Research Strategy. So he oversees the Office for Research. As I touched on before, we have Dr. Di Lawrence, the Executive Director of Medical Services, who oversees Standard 1, that's the clinical governance. And then we've got Justin Prendergast, he's the Executive Director of Nursing and Midwifery, and he oversees Standard 2. So that's some of the leadership that we have here at Sarlan. But what we thought we'd do, we'd try to visualise some of the flow of operational activities and how everything works. So we've got we have a board here that commenced in 2019, along with the other LHNs in South Australia. We have our Chief Executive Officer, Dr. Kerry Freeman. She commenced with us mid-July. So that's the leadership. Then we look at the operational aspects. So there we've got divisional directors, as I touched on. We've got Andrew Burston, Di Lawrence and Justin Prendergast as the executive sponsors for the National Clinical Trials Governance Framework. Then we have our heads of departments, and then we have our workforce. That's the bulk of our 8,500 staff, and through that we've got our induction and education systems. And so we've gone for a wide sort of variety of methods that we're trying to communicate with our workforce and engage with our workforce. And then that also provides us the opportunity to strengthen our partnership approach. So we work very closely with our philanthropic partners. So we've got Flinders Foundation, the Hospital Research Foundation here today, and they're supporting us with a internal grant round of $1 million this year, which Andrew Burston launched on Monday. We've got our academic partner who hosted hosting this conference with us, Flinders University. We've also got industry partnerships. So we've got MTP Connect here, who are a really sort of bridging group to bring different parties together. We've also got Bellbury and CTIQ that work on a national, with a national scope, which are based here in South Australia, and they're great to work with as well. And I'll touch on some of the things with CTIQ later. And then we've got our alumni, students. So we had Blackwood High School here today. We've had high school students here throughout the week. And then we've got professional development opportunities for our staff. And so I guess that's around kind of understanding your purpose and some of the joy at work things that Grant Phelps discussed here at Research Week on Wednesday. Then we move into this inquiry space, and that's where we have the 4 fields of inquiry. And that's how we sort of communicate research to our workforce. And that includes continuous improvement, implementation science, health services research, discovery science, and clinical trials. And that's the theme for today. And with that, we're looking at further developing the alignment with our improvement unit. It's led by Angie Goodrich to look at some form of innovation, improvement research service where new ideas can head down the continuous improvement path following clinical governance, action 1.28 around clinical variation, or down the research path and follow the national statement. So we've got the national statement and the national standards. We've also got the Sarlan Research Council, and so there's broad executive support in that council, as well as partners across South Australia as well. So Karen will touch on some of the strategic considerations that we have.
Okay, so our strategic oversight commences with our direction map. So underneath our direction map, we have 4 pillars. So this incorporates our clinical services, our consumers, our relationships, and our research. And all of these do not operate in a silo. In terms of embedding the strategies, they're all embedded into each other. So, for example, research is embedded into the other 3 pillars in all of the strategies. Underneath each of the pillars, we have a number of frameworks which ensure that we're meeting our consumer needs.
So we have drill down the next level to the organisational structure, looking at some of the team that we have, as we touched on. Professor Andrew Burston provides oversight, and then we've got the Office for Research team, and we've worked very closely with the clinical governance teams as well as partnering with the consumers teams over the last 3 years, really, to work through the different iterations of the National Clinical Trials Governance Framework with the now arriving at the February 2022 final version, which fortunately wasn't too different from the others, so that was good. And so yeah, that's the structure of the office itself. And some of the services we provide is obviously the office was primarily initially developed around the Ethics Committee and the Southern Adelaide Clinical Human Research Ethics Committee, as well as the governance. But now it's very much evolved to around the engagement and collaborations, very much an education role, as well as now grants management and seeking that investment to give our staff more opportunities. So I thought I'd touch on some operational aspects as well, and this graphic is from the Commission, which looks at basically the whole structure of evidence-based practice in a health setting, where we've got the trial initiation, site selection, and the bit that I've highlighted there is the ethics and governance review. As Bernadette touched on, there's a range of measures that the Commission's working on to optimise that further. And then we've got the trial commences, and then we go through all of the different aspects of the trial management. So the screening, the workforce management, financial management, safety, the progress reporting and amendments, monitoring, and then through to the dissemination of the results. And from that, from the bit that I've highlighted there at the top of the diagram, in 2020, the Department of Health incorporated performance metrics into our service level agreement. So we've had that for 2 financial years. I think New South Wales was one of the first jurisdictions to implement that performance metric. So yeah, we've had it in South Australia for the last 2 years, and yeah, Sarlan has been we've got the three metrics. So 60 calendar days for a ethics review, 30 days for a governance review, and 20 days for a low-risk joint ethics and governance review. And across the 6 KPIs there, we're above the 85% target for that. So that's the some of the operational aspects.
Okay, so at Sarlan we've developed a clinical trial framework, and this was primarily to assist our clinical trial workforce to make decisions in relation to safety and quality and integrity when undertaking research at Sarlan. So our framework is, it aligns with Sarlan's strategic directions, our quality plan and our integrated management system, but it also incorporates the 5 principles outlined in the National Clinical Trials Framework.
Hello, my name's Simon Windsor. I'm the manager of the Office for Research at Southern Adelaide Local Health Network. In 2023, the Australian Commission for Safety and Quality of Healthcare will introduce the National Clinical Trials Framework. This framework is part of the National Standards Accreditation for Public and Private Health Services. Here at Sarlan, we've developed the Sarlan Clinical Trial Framework, and our framework has 5 objectives. Firstly, partnering with consumers will be at the centre of everything we do. We'll demonstrate strong research governance, leadership and culture through strategic direction and oversight. Our workforce will have access to education and training that will enhance their clinical performance and effectiveness. We'll provide a safe environment for the delivery of our clinical trial services. And finally, we will continuously improve the safety and quality in patient care.
Hi, I'm Karen Saxty. I'm the Research Governance Officer at the Southern Adelaide Local Health Network. During accreditation, researchers need to have a clear understanding of the National Statement and the Australian Code for Responsible Research. They need to ensure that they maintain excellent records in accordance with their ethics and governance approvals, and they need to ensure that they store their data securely. They need to document the patient journey well in Sunrise, and they need to review the care that they provide by undertaking quality improvement activities regularly. And they need to involve their consumers in every aspect of their research.
So our implementation strategy for Standard 1 is that we have an integrated governance framework, as mentioned earlier. So this means that our governance of our clinical trials incorporates our consumer governance, our clinical governance, corporate governance and research governance. And as Simon alluded to earlier, we have a very strong organisational structure. In terms of operational metrics, we have SA Health standards that the Office for Research is aiming to meet, and we monitor these on a regular basis. In terms of our clinical trial activity, we're working with our Sunrise EMR team to document all clinical trial consent forms so that we can document our activity via our health systems. We have delegated roles and responsibilities to oversee the accreditation process, and we also have a risk management policy. In terms of safety and quality performance, these are measured via the safety learning system, via our continuous improvement activity, and also through patient feedback, through our patient feedback guidelines.
And I'd just like to quickly shout out the photo here. That's some of the crew there that has delivered this week, and it's been remarkable. We've had 600 people register. We've been, lots of people fly from interstate, and I think it's really encouraging that Incorporated Hospital is ambitious enough to deliver a program like this. So it's been a really exciting week, but I'll need a good sleep tonight, I think. And the second standard, obviously partner with consumers. We've integrated very closely with the delivery of that standard as well. So getting research embedded in our consumer and community strategic frameworks. Last year we developed a research framework for consumers and working closely with our research partners, and that includes building in consumer involvement into our funding models for our internal grants. Health literacy initiatives, so once again I'll shout out Sonia from CTIQ. I've been working very closely with her for the last probably almost 2 years now, and the first time we've caught up in person, because everything's been COVID and Zoom and whatnot, on the Inform project. So the aim of that project is to develop a national consent form that's consistent for research across all jurisdictions, and it would discuss it with Bernadette. It fits really nicely with this clinical trials front door. We've partnered with consumers in organisational design and governance as well. So consumers are on the Southern Adelaide Clinical Human Research Ethics Committee, and ensuring we get consumer feedback and our complaints are monitored appropriately, and that's really embedding it in with our consumer advisory service, so then that can go through to exec and board as well. And then we also have our stakeholders, which are our researchers. So the 3 wheels below, that's the annual stakeholder survey that we put out to recent customers. So within that year we give them some survey to see what their experience was like, and over the last 3 years we've seen a steady improvement of that green aspect of the ring to very positive 91%. So there's always room for improvement as well. And also looking at Aboriginal and Torres Strait Islander specific actions, and so a lot of that's been around the ethics and governance processes, working closely with the Aboriginal Research Ethics Committee here in South Australia and the Aboriginal Health Research Council, and looking at ways we can streamline that to encourage more and more appropriate Aboriginal research. And then also developing a calendar of events and engagement activities. So that includes the event that we had on Wednesday, which was Aboriginal Patient Journey Workshop in this room here, and it was extremely well attended. Karen took that photo, so excellent work there. And yeah, another event that we're looking at, so this one was done with the Lowitia Institute. but Loitia O'Donoghue, she was a member of the Stolen Generation and actually was at Colebrook House, which is in Eden Hills. So it's only 3 kilometres from here up the road. So, and she has had a remarkable life, and went from Colebrook House and then spoke at the UN 30 years ago in 1902. So she's been an amazing journey, and so we want to do something around that story as well. So another key aspect of the National Clinical Trials Framework is education. And we've got 2 special guests here as well to join us. And we've got Jessica Southwood and Tamara Hooper. And Tamara is from Health Translation SA, and Wendy Keach chaired a session for us on Tuesday, which was fantastic. And Jessica's from the Regional Clinical Trial Coordinating Centre, and we've got Paul Worley talking this afternoon about the opportunities that teletrials will provide rural and remote communities. So I would like to welcome you both to the stage.
Thank you, Simon. I'm Tamara.
Oh, and I'm Jessica.
Just in case you didn't know. And thank you so much. It's been lovely to be back on Flinders soil this week, where I first started my research career under Andrew Burston. So I guess what we've got here is a sharing of an opportunity for all staff, or in fact for all South Australians, not just staff, really. So VC Tech is a Victorian clinical trials education centre, and it was actually being led by the Victorian Research Translation Centres, which you can see all of the little icons across the bottom there. So the vision of the Victorians was really to build the capacity as well as the capability of the clinical trials workforce through easy access to world-class education and training opportunities. So this fabulous opportunity that we have for everybody has been brought to you by the SANT Regional Clinical Trial Coordinating Centre in the Office for Research in the Department of Health and Wellbeing, under Ben Shaw's, who's at the back there, and also partnering with Health Translation SA to bring this to you. So what is VC Tech? It's an online education and training platform for anybody really that's involved in not just clinical trials but any sort of research. It's an interactive, practical, multimodal, evidence-based platform. Within the platform there's also networking opportunities as well as workshops and webinars. And most importantly, as you can see there in the bold, that it's actually free for all South Australians. So not just SA Health staff, but certainly we're going to be promoting it out through all of the health translation partners, universities, CSIROs, as far and wide as we can possibly get it going. So what's next? So as of Monday early this week, we now have the opportunity for new users to actually register in VC Tech, and you'll see there's a link there. We're also holding a webinar on the 20th of October from 1 till 2, and you can see there's a link there to RedCap and a QR code. So feel free to register for that. So that'll be run by us. So far, I think we've got 60 people that have already registered. So that's quite good. We haven't done a huge amount of promo yet. There is a bit more information on the Health Translation SA website, and also feel free to get in contact with either Jess or myself. But I guess there's some more exciting stuff coming too, isn't there?
Yes, thanks, Tamara. So I'd just like to add that while this has been designed for Victoria, South Australia is the first jurisdiction outside of Victoria to get access. And as Tamara said, we're delighted to be able to bring this to South Australia, and it's at no cost to the end user. and other jurisdictions will be coming on board in the coming months, and there will be opportunities for South Australian users to provide feedback to us, and also you can have input into new modules that can be added to the platform, and the intent is to make this an Australian platform. It will be rebranded to an Australian system rather than specifically Victorian, and that's coming up over the coming months. There's also going to be some GCP training modules coming soon, and all the national partners from the Australian Teletrial program, we're looking at getting specific teletrials training modules put up. And I'd also just like to add that if you'd like to find out more about the Teletrials program, please stick around. Professor Paul Worley has a presentation coming up after the next break. Thank you.
Thank you. So, any questions from our audience, or I'm just checking the app. There aren't any on the app at the moment. I think that's actually been a really, really informative session. Thank you, Bernadette, and thank you to all of the speakers. Thank you. I've certainly, my understanding has gone up a significant notch, which is really important as the executive lead for clinical governance. I also want to acknowledge that we've got one of our Salem board members here, Jill Noble. So the board take this very seriously, and it's great. Thank you, Jill, to see you here. We've got Peter King here, our lead consumer. So yeah, fabulous attendance. So thank you, everyone. And we'll break for morning tea and then back after morning tea. Thank you.